The broadcast is now starting. All attendees are in listen-only mode.
Hello, and welcome to our webinar on long-term care. Where are we and what's next?
Muted.
My name is Catherine Martucci. I'm the Director of Policy and Programs at the Alliance for Health Policy, and I will be introducing today's discussion. For those that are not familiar with the Alliance, we are a nonpartisan organization dedicated to advancing knowledge and understanding of health policy issues. We do not lobby or advocate or take any policy or political positions ourselves. Instead, our mission is to educate the health policy community. During today's webinar, our panelists will explore the landscape of our current long-term care delivery system, its funding mechanisms, and the impact that it has on stakeholders such as older adults and caregivers. The Alliance for Health Policy gratefully acknowledges the National Institute for Healthcare Management Foundation for supporting our Beyond the Beltway Health Webinars for Journalists series. We would also like to thank the Association of Healthcare Journalists for their help in shaping this series. If you're interested in joining the Twitter conversation, you can use the hashtag AllHealthLive and follow us at AllHealthPolicy. I want to briefly orient you to the GoToWebinar platform and go over some technical notes. We've taken a screenshot of the attendee interface, so you should see something that looks like this on your computer desktop in the upper right-hand corner. You can click the orange arrow to minimize and maximize this menu. And when you joined today's webinar, you were muted, and you will be throughout the presentation. You can use the question panel to chat with us about any technical issues that you might be experiencing, and also you can send questions that you may have for the panelists there at any time. We'll be collecting those throughout the broadcast and addressing them. So here's our agenda for today. First, we'll have each of our panelists make some opening remarks to orient you to the long-term care system. And then we've allotted plenty of time for audience Q&A and moderated discussion. So again, feel free to be sending questions at any time. You'll also find all of the materials that accompany this webinar, including a copy of the slides, a resource list, and an experts list on our website, allhealthpolicy.org. And then a recording of the webinar will be made available there in a couple of days. So now I have the pleasure of introducing our guest moderator for the day. Rachana Pradhan is a healthcare reporter for Politico, where she focuses on Medicaid and ACA private insurance markets. Prior to this position, she worked at Inside Health Policy for 3 years and was also a city government reporter at the Daily Progress in Charlottesville, Virginia. She is a recognized health policy expert and has appeared on multiple media platforms such as CNN, MSNBC, Fox News, and C-SPAN. So we are very honored that she has decided to lend her expertise and her moderating expertise with us today. So with that, I will hand it over to you, Rachana. Who's maybe on mute? Rachana, are you?
I am. Can you all hear me?
Yep, you sound great.
Great. So let me just, I'm going to briefly just introduce all of our panelists who are joining us today, and then we'll get started right away. So first is Anne Montgomery. She is the Deputy Director at the Altarum Institute's Center for Elder Care and Advanced Illness, where she manages a portfolio centered around the coordination and integration of medical care and long-term services for the aging population. Anne was formerly a congressional staff member for both the Senate Special Committee on Aging and the House Ways and Means Committee. Next, we have Gene Axios. He's the Senior Vice President of Thought Leadership and International Affairs at AARP. He provides expertise on the aging population both domestically and internationally. Gene has been recognized as a Gerontological Society of America Fellow and received the Share Care Award for his groundbreaking work documenting male family caregivers. Next, we have Camille Infusi-Dobson, who's the Deputy Executive Director at Advancing States, where she provides guidance to state aging and disability agencies on managed long-term services and supports and quality management. Prior to her current role, Camille worked at CMS for 10 years managing Medicaid policy and operations. Finally, we have Maureen Hewitt, who's the President and Chief Executive Officer of InnovAge. In this role, she leads the strategizing and growth of the largest provider of PACE. So now we're going to have Ann Starr, who will go over for us the current state of long-term care.
All right. Well, good afternoon, friends and colleagues, and many thanks to the Alliance for Health Policy. It's one of my very favorite organizations, and that's because I had the honor of working there years ago with Ed Howard and also alongside Sarah Dash when we were both serving on Capitol Hill. Okay, next slide. So here's a little bit about Altarum, just to give you a sense of what we do. We're a health services research organization, and at the Program to Improve Elder Care, which I now have the privilege of co-directing, we work hard to come up with solutions that improve any number of aspects of elder care. And we have projects looking at financing, quality workforce, and more. Next slide. This is a comparison of where we've been and where we're going, and this is over only 10 decades from 1960 to 2060. I think it's an astonishing demographic shift, and I never really tire of marveling at the progress that this slide highlights. Notwithstanding political turbulence, we've made huge progress in providing better and better healthcare services, and our public health system has done wonders in preventing and controlling infectious diseases. Now we're in an era where chronic disease and the functional limitations that characterize old age are becoming paramount, and that's what we're talking about today. Next slide. Spending, however, current spending is not reflecting the needs and priorities of a surging older population of frail elders, who need access to an array of non-medical supportive services, such as those covered by the Older Americans Act. You can see the yawning gap here. This chart focuses on Medicare and the contrast between spending in that program and the Older Americans Act. And the gray bars represent population growth. We'll talk about Medicaid a little bit later. A decade from now, that upward curve for Medicare is projected to go up far more sharply unless we make significant changes starting now. And we're in the process of adding tens of millions more older Americans who will be increasingly seeking long-term care. So it seems very important to quickly engineer a series of multiple changes in service delivery through policy shifts. And that means working with Congress, with states that mainly administer Medicaid, and with local governments and willing stakeholders. We have a great panel to discuss all this. In other words, our abbreviated timeline of 10 years suggests it would be a good idea to develop a strategy that we all work from and that can be rapidly executed and which modifies and improves on what we have in place. And that's the angle I'm going to be taking today. Next slide, please. Let's talk about what states can do first. We know that states have done a lot over the years to diversify their LTSS systems, but there's still a ways to go. Here are data that show this from IBM Watson Health, from all states except California and South Carolina. In terms of HCBS spending, we have states that range from 27 to 81% of their total long-term care spending, and the average is 57%. There are major disparities between populations, with 78% of LTSS spending on the I/DD population dedicated to HCBS, compared to 45% for older adults and individuals with physical disabilities. We have an awful lot of people on HCBS waiting lists, 656,195 across the country in fiscal year 2016 for 1915C and 1115 waivers alone. So how can we best address these challenges? Next slide. Here's one way. We can shape an initiative to expand the infrastructure for HCBS. There is no conference on long-term care that I've ever been to that doesn't note the incredible lack of capacity that we have in affordable, accessible, disability-adapted housing, in the direct care workforce, in transportation supports for people who use wheelchairs, and in supports for family caregivers. Such an initiative is in the making right now. There is interest both in the Senate and in the House of Representatives in shaping a bill that will be called something like the HCBS Infrastructure Improvement Act, and it will propose substantial grant funding for states that submit plans to make clear progress in continuing to shift their LTSS spending toward HCBS along with coverage gains, and that build infrastructure in these areas. Next slide. Without getting too much into the weeds, such a program, and it would not be small, would be a major one-time investment in state HCBS capacity. A similar program that ran for 5 years, the Balancing Incentive Program that I was privileged to work on when I was on Capitol Hill, provided states with grants to make gains, and they all did. And they got FMAP enhancements, federal matching assistance percentage enhancements to do the work. So there's already a solid, successful precedent for this approach. And here's how a formula could be constructed. We've done an initial run using these percentages for what states would get in terms of additional funding. These are the percentage increases states could apply for relative to their HCBS baseline spending. And as you can see, similar to the Balancing Incentive Program, states that needed the most help to make progress in shifting to HCBS would qualify for grants at a higher percentage. In the last couple of years, we suggest also tying the funding not only to spending, but to enrollment gains as well, with states that are already well along the HCBS trajectory, those getting 0.25%, being required to hit a target of moving 85% of their LTSS population to the HCBS sector. And states getting a 0.5 increase would be required to achieve a 75% of all Medicaid beneficiaries enrolled in HCBS settings, and so on. A program like this could be 5 years or 7 years or some other duration. It could be capped in total funding, or it could be open-ended. It could make all of the targets mandatory that we saw in the last slide, or only some of them. So there are lots of levers and ways of making it work to fit the political circumstances of the House and Senate, and we'll see what's possible. But if we can do this, it will result in enormous improvements and gains in long-term care. And because housing and transportation and workforce are essential to Medicaid but not in Medicaid, there would be a great deal of work done in information technology in order to coordinate and integrate with programs that are administered by other agencies. Next slide. Now I'll turn to Medicare and offer up two practical ideas that I hope you'll like for making progress in the near term. One focuses on Medigap, which has more than 13 million policies out there, and which could be used to offer a low-key and potentially actionable way to tackle the front-end risk of needing long-term care. Medigap is purchased by beneficiaries in the Medicare fee-for-service sector. We've already taken good steps to improve the Medicare Advantage program a couple of years ago with regard to enhancing MA plan flexibility to offer optional supplemental LTSS benefits. So the basic idea of this is, why not do something similar on the fee-for-service side? If Congress wanted to do this, we could build on the expertise of the National Association of Insurance Commissioners, which represents state insurance regulators across all states. NAIC develops state model laws. It created the original framework for the Medigap market when Congress directed it to do that in a 1990 law. So if the Ways and Means and the Finance Committees decided to slightly expand Medigap, they could call for NAIC to develop a modest, limited array of in-home supportive services for personal care assistance, for home-delivered meals, for care coordination, and perhaps a few other services. These are services that have been studied in depth by actuaries in Minnesota who have projected only a modest impact on Medigap premiums. There are ways of improving comprehensive long-term care insurance too, and there will be testimony to that effect later this week in the Health Subcommittee of the Senate Finance Committee. In general, however, the long-term care insurance market has been struggling and premiums have been going up, and for many existing policyholders that's presented difficulty. So it's a troubled market. Next slide, please. In thinking more about existing Medicare programs and how we can enhance and scale them, PACE comes to mind, and I know we'll hear more about that later. At Altarum, we've been looking at PACE for the last couple of years and how it can be used to slow spend down to Medicaid, because Medicaid won't be able to fully absorb millions and millions more older adults who are accessing it mainly in order to get long-term care. We simply must build better capacity that Medicare beneficiaries can easily and reliably access and use. And what we're recommending for PACE is to create a clear pathway to enroll Medicare-only beneficiaries, which is really very difficult today. To make that happen, we're going to have to reduce the cost of Part D coverage, which is astronomically high due to a statutory conflict between the 1997 PACE originating statute and the 2003 Medicare Modernization Act that added prescription drug coverage to Medicare. Today, if you're a Medicare beneficiary wanting to buy into PACE and you can afford to pay for your own long-term care because you're not eligible for Medicaid, you're forced to buy the PACE Part D plan, which is 10 to 20-fold more expensive than a regular standalone Part D plan. There are many reasons for this sticker shock, which we can talk about during Q&A if you're interested. But right now, let's skip to the solution, which is to give Medicare beneficiaries a choice of buying either a local Part D prescription drug plan, which is often about $50 a month, or the more costly PACE Part D plan, which can run $800 to $1,200 a month, depending on where you are. And if we take this step, then I think we can include PACE in the array of first-class Medicare providers. Next slide. And then we can do a lot more. We can take PACE and make it the healthcare hub for a locally anchored system of care that connects with many, many different community-based organizations that offer supportive services. I'm thinking of those in the Aging Network and elsewhere. The hub could be an MA plan too, or perhaps a federally qualified health center or some other healthcare provider. But PACE, with its community infrastructure, its medical centers, its salaried interdisciplinary teams, its reliable transportation system, has a long track record of serving communities really well and not pulling in and out depending on quarterly earnings. So it's poised to do a particularly good job. The various components of this puzzle piece are basically how we at the Program to Improve Elder Care, with thanks to Joe and Lynn for leading the way, conceptualize what a community-anchored mixed healthcare and long-term care system would include. And we can talk about that more if you're interested. Next slide. Now I'll just say thank you. Thanks so much.
Great. Thank you so much, Anne. And so now I'm going to turn it over to Jean. And Jean is going to discuss older adults, caregivers, and existing federal programs. Take it away.
Great. Well, thank you very, very much. And thank you, Anne, for that great presentation. I thought that what I would actually do is just kind of give you some background information in terms of AARP, and then give 4 key takeaways from my presentation today. So if we were to go to next slide. So I'd like to just kind of start off by just kind of giving you a sense in terms of exactly who we are as an organization. We were founded over 60 years ago by Dr. Ethel Percy Andrews, who was a retired principal who went looking for a retired friend, who was a retired teacher, and found her living in a chicken coop. And outraged by that experience, she created AARP, an organization founded with the full focus of ensuring that older adults could age with dignity, independence, and purpose. And for more than 60 years, we've been on this mission. So we're a nonprofit, nonpartisan organization. We're dedicated to empowering people to choose how they live as they age. We have over 38 million members and offices in every state, Puerto Rico, and the U.S. Virgin Islands. And every day we work to strengthen communities and advocate for what matters most to them, as well as their families. And that primarily focuses on health security, financial stability, and personal fulfillment. Next slide. So there are a couple of key takeaways from our presentation today. The first one is that the population is aging, growing, and living much longer. The second is that the demand for long-term service supports will more than likely increase. The third is that as baby boomers age, there will be fewer family caregivers to support them. And then there should be one more bullet there that talks about now is the opportunity. And that opportunity is to really think about innovative solutions that cross across public and private sectors to help address the challenges and ensure that people can actually age with options. Next slide. So this slide gives you a good sense in terms of exactly the population growth and why we're having this conversation today. There's about 10,000 people who are turning 65 each and every day. And according to the U.S. Census Bureau, that within the next couple of years, the number of older adults will exceed the number of children for the first time in U.S. history. And this has significant implications, particularly for the work that we're doing, and thinking about how this might impact communities, sectors, and systems. What you see on this slide is that the population ages 85 plus, which is the cohort that's the highest need for long-term supports, is projected to triple between 2015 and 2050. And you can also see the growth by the other population as well. So the fastest growing age group is the 85 plus population, and then the second fastest growing is the 75 to 84. So we have a tremendous opportunity to think about exactly what does it mean in terms of a population that's aging and growing and living much longer. And then the other aspect I would just say is the fact that this also has implications for family caregivers. Next slide. As you can see by this slide, the cost of long-term supports exceeds what families can afford across the country. The average cost of a nursing home in the United States is roughly about $97,455. And for a private nursing home stay in the U.S., what you see here is the fact that it would consume about 231% of an older middle-income family's income. For a semi-private room, you're looking at about $87,600, and that would consume about 208% of someone's income. When you look at the median rate of a private bedroom in an assisted living facility, it's roughly around $45,000 a year, and that would have consumed roughly about 107% of a typical older family's income. And then just looking at home care, which is roughly around $33,540 a year, and we're just making an assumption here that this is care for about 30 hours a week from a licensed non-Medicare certified home health aide. And what you see here is that would consume more than 3/4 or 80% of the median income of older households. So one of the key points when you look at this slide is the fact that the high cost of long-term service supports is unaffordable across the country and for most Americans. Next slide. Family caregivers are the backbone of our long-term service support system. We just released a major report last week looking at the value of family caregivers, and there's roughly about 41 million family caregivers in the United States. These are family members, neighbors, friends who are helping each other and providing what many would consider to be very complicated medical nursing tasks, such as giving injections, wound care, tube feeding, in addition to helping with bathing, eating, dressing, as well as providing assistance with transportation, finances. And family caregivers provide the majority of long-term service supports in our country, and they are critical partners in helping individuals remain in their homes and communities. And caregiving is now a widespread issue, is a public issue, in part because of the fact that so many people are caregiving or likely will become a caregiver. And this crosses all political ideologies. This crosses all different age groups. 1 in 4 of caregivers are millennials. 40% of caregivers are men. So there's a great opportunity to think about ways in which to actually support family caregivers. The report that we released last week found that family caregivers provided in 2017 roughly 34 billion hours of care, and the economic value of that unpaid care was roughly around $470 billion. So if you take into account that we have a population that's aging, that the vast majority of individuals receive care from a family member or friend, and that these family members and friends are providing care at the tune of about $470 billion on an annual basis. And then you take into account that the number of family caregivers will unlikely keep up with the pace of the aging of the population. There's some opportunities to think about ways in which we start to support and recognize these family caregivers. What you see on this slide is just the ratio, and what you can see here is that that there's almost 7 caregivers for every one older adult, and by 2050 that declines from 7 family caregivers to 1 older adult. Next slide. In addition to these caregivers providing the care, they experience significant out-of-pocket costs. We did a study in 2016 that found that the average family caregiver was spending about 20% of their income on caregiving activities, so that's roughly about $7,000. And for caregivers who were providing care for long distance, that was roughly about close to $12,000. Next slide. Several years ago, in 2011, the ARP Public Policy Institute created the state scorecard. This right here is, we started this conversation back in 2011, wanting to get a sense as to what is a high-performing system? What would that actually look like? And we worked with a national advisory group, and we came up with a framework that basically highlighted these 5 dimensions, and that a high-performing system would be affordable and accessible, that there would be adequate choice of setting and a provider, that quality of life and quality of care would be critically component to the system, that there would be support for family caregivers for many of the reasons I just mentioned in the previous slides, and that there would be effective transition between one setting to another. Next slide. just to kind of give you a sense. So this framework was further operationalized that in a high-performing system that consumers should be able to easily find and afford the services that they need, and that there should be a safety net for those who cannot afford these services. Under choice of setting and provider, that the system will be person and family-centered, and that there will be a place of high value on allowing consumers to exercise choice and control over where they receive services and who provide them. Under quality of life and quality of care, this is looking at the opportunity to really ensure that the services maximize positive outcomes for consumers and that they're treated with respect and that their personal preferences are honored, going back to what I was referring to in terms of our founder and her vision for older adults in this country. And then that in terms of support for family caregivers, that family caregivers, their needs would be assessed and addressed so that they can continue to provide their caregiving role without being overburdened or stressed. And that in terms of effective transitions, that there would be seamless transition between one setting to the next. So when you look at these 5 different dimensions, we were able to collectivize data under each dimension to be able to assess how a state is actually doing. So the scorecard is multidimensional, where you can actually look at state performance at an indicator level or at a dimension level, which is these 5, and then overall. Next slide. And what you find here, these are the overall rankings. So when you take into account the 25 different indicators across these 5 different dimensions and you get an overall score, what you find is the fact that there's great variation across the United States in terms of the systems of care with respect to the delivery of long-term services and supports. And we can get into a conversation in terms of exactly what are the opportunities here. When we released our scorecard back in 2017, the #1 state was Washington. Oregon and Minnesota were not too far behind. California is ranked 9. And we can talk about some of the other states as well. The wonderful thing about this scorecard is the fact that even the high-performing states like Washington State, Oregon, or Minnesota, or California, there's still opportunities, particularly at the indicator level, to improve. So there's always opportunities to continue to improve to deliver services for older adults and people with physical disabilities. Next slide. So some of the key findings from this report is that states must pick up the pace of change to meet the needs of a growing number of people who are aging and also living with a disability. As I indicated before, you have a significant population who's aging and needing services. The other point from this report is that where you live matters significantly. And we can get into this conversation as well. And what are some of the policies that are in place to think about ways in which we can ensure that people can receive services in the setting of their choice, and that is also cost effective. The third key finding is around measurement. And what we found was the fact that for those indicators where there was attention, whether it was federal and state initiatives, Anne talked about BIP as a perfect example, and state stakeholder engagement, we saw a significant movement, particularly for those indicators. And then finally, Medicaid is a major driver of change, and I know that Camille is going to get into Medicaid. So next slide. So where do we go from here? Some of the things I think that's important to think about, and we can have this conversation, is that as we think about strategies for not financing long-term services supports because the cost is unaffordable for the vast majority of Americans in this country, it's important to think about what are those public and private sector solutions. No one sector can actually address the financing question by itself. So really thinking about exactly what are the opportunities, which gets to my second bullet, around the shared responsibility of the appropriate role for government, for individuals, and private sector. Giving the significant support that families and friends are providing in terms of the care that they're providing is critically important to think about ways in which we can recognize and support them. And there's been some great efforts and great initiatives, particularly around the National Advisor, the RAISE Act, that's focused on looking for, across the federal system, looking for innovative ways to support and recognize family caregivers. The other bullet is around innovation and encouraging experimentation with new ways of organizing care. You heard some ideas from Anne, and many states are in different conversations about different innovations that they want to implement. The other bullet I would mention is that one of the key things we know from constant surveys that we've done here at AARP is that the vast majority of people would prefer to remain in their homes and communities for as long as possible. And oftentimes, receiving services in your home is more cost effective than going to another setting. So thinking about ways to ensure that there is that the policies that are in place are on equal footing around going into an institution relative to going into a home and community-based services to receive care is critically important. And then finally, as we think about the delivery system of the future, we want to ensure that it is really focused on the person and the family, and that the system is being responsive to their individual needs and their preferences. And then finally, I just want to say thank you. I think this is a great conversation, and I am looking forward to the questions.
Great, thanks so much, Jean. Now we're going to turn it over to Camille, who will be reviewing programs at the state level.
Thanks so much for having me today. Good afternoon. For those of you that do not know who we are, Advancing States is the new name for the National Association of States United for Aging and Disability, or NASHUID. We represent state aging and disability directors who manage LTSS programs at the state level, both Medicaid funded and non-Medicaid funded. We focus our efforts here as a membership association on helping states deliver high quality long-term services and supports, both to older adults and people with physical disabilities. Next slide. So as Ann and Jean both mentioned, family caregivers provide the bulk of unpaid care for individuals who need LTSS in the country. But for paid care, after out-of-pocket costs paid by consumers and family members, Medicaid is the largest payer of long-term services and supports. As you may know, there is little to no Medicare coverage for long-term services and supports past acute skilled need for nursing home care. There is virtually non-existent employer private coverage for LTSS, and sadly, there are few individuals who actually have long-term care insurance policies that might cover LTSS. So really, Medicaid is the focal point for conversations about delivering and sustaining long-term services and support systems. Next slide. So as I said, states and our partners in the federal government really are on the hook to address the growing demand and need for long-term services and supports that both Ann and Jean mentioned. This slide is top of mind for our state agencies. While most people think that Medicaid is covering pregnant moms and kids, and they do, in fact, in terms of pure numbers, most of the expenditures, more than half of the expenditures, though, that states make are for older adults and people with disabilities. And so addressing that component of the Medicaid program is really top of mind for states. Next slide. This is the same data that Ann showed in the map format. I like this one better because it's pretty clear from top to bottom where states are in terms of successfully spending as much of their Medicaid funds as possible on community settings, which, as Jean said, is where most people would like to receive their services. The national average is right now around 57%. There are a number of states, you can see the same kinds of states that were at the top of the LTSS scorecard from AARP are also being very successful in delivering services in community settings. But there's a lot of opportunity for those states in the upper half of this chart to make inroads into serving people in the community and not in institutional settings. Next slide. As Ann said, that graph is actually very misleading because it includes all LTSS expenditures. And as Ann mentioned, individuals with intellectual and developmental disabilities are largely, not in every state, but largely served in community settings. And so it skews the average upward in terms of HCBS expenditures. What it masks is the fact that only 45% of older adults and people with disabilities are served in community settings. And while that's an increase, a great increase since 2002, when less than half of those individuals were in community settings, there are lots of opportunities to serve individuals, both to divert individuals from entering nursing facilities, as well as identifying individuals who can safely live in community settings. Next slide. So one of the activities that states have undertaken in the last 5 to 7 years to address the challenges of growing demand for LTSS is moving their systems to a managed care delivery system. We call that MLTSS, Managed Long-Term Services and Supports, and it's a system in which, like most Medicaid individuals who are also in managed care, the state transfers both responsibility and payment for long-term services and supports to capitated managed care companies, both for-profit and not-for-profit in their state. It can include both institutional services like nursing homes, as well as home and community-based services. But the state itself decides which LTSS services the health plans will be responsible for. Next slide. So these are a number of the reasons why states are pursuing MLTSS programs, and you can see many of those address the challenges that both Ann and Jean have already laid out. States are able to use health plan contracts to drive accountability rather than having, individual contracts with 4,000 or 5,000 providers. They can focus their time and attention really on a handful of health plans with strong and vigorous contract requirements that demand high performance from the health plans. States have also had some limited success at this point addressing the waiting list that Ann mentioned. There are a number of states around the country that have more demand for home and community-based services than they have capacity to provide, mostly because the Medicaid program requires the states to offer nursing facility services as a benefit, but does not require them to offer home and community-based services. And so states are challenged to manage that balance, and they have found health plans are effective partners in helping to move individuals off of HCBS waiting lists and into services. Back to the graph that I showed, most states are very interested in achieving some system balance. Rebalancing is really a misnomer because the system is never balanced to start with. But really, the health plans have also been effective partners in working with the nursing home industry and HCBS providers to build additional capacity for community-based services. And the way they are paid, frankly, in most states, gives them a financial incentive to try and serve individuals in the community, since that is the preferred and less expensive option. Third, the states are interested in improving the quality of their LTSS system, and plans have a natural quality infrastructure that they can apply to long-term services and supports. Plans also have, frankly, more flexibility to pay for services than states do. It's a long-standing conundrum, but nonetheless, the health plans can use their capitated funds in a more flexible way that allows individuals to maybe get services that might not otherwise be available to them in the fee-for-service system. It also allows the person to be at the center of services. In other words, a system that's both looking at not only their long-term services and supports, but also their acute care needs. And we find that in many states, MLTSS programs have increased the number of older adults and people with disabilities that are getting preventive services when they have historically been underserved. And then last but not least, fee-for-service systems tend to be unpredictable as the state just continues to pay claims sort of without knowing what's going to be coming next. Managed care capitation payments do provide a measure of stability and predictability for the state Medicaid programs, and we have found in a handful of states that have been doing this for a while that while Medicaid costs have not gone down, they never will probably go down, but they have in fact slowed the growth in per person costs that the state was facing in the fee-for-service system. So these, appropriately deployed, managed care can be a really effective tool for states to try and address both quality innovation, as well as the growing demand for HCBS. Next slide. This is a snapshot of what where managed care for LTSS currently exists in the country right now. There are 24 programs that are either statewide or regional. Those include the financial alignment demonstrations, the capitated financial alignment demonstrations that were funded through the Affordable Care Act. Right now, there's not a lot of activity to move into additional states, but there are great opportunities in a number of the states in the Midwest and the South that have managed care programs for the TANF population and the low-income adult population that could be applied to LTSS programs. Next slide. I think that's it for me. I'm going to turn it back to Catherine.
Great, thanks so much, Camille. Now, finally, we're going to have Maureen, who's going to review the program of all-inclusive care for the elderly, or the PACE program.
Hi, this is Maureen Hewitt, and thank you for allowing me to join today and for including PACE as part of the discussion. It's such an important one today. I've had the privilege of serving the organization for the last 12 years and have intimately learned just how important this population is and just how complex it is in developing the program that is really needed. Page 2, please. So our mission is to sustain and enhance the independence and quality of life for those we serve on their terms. We believe this is very key in our organization. We believe we're committed to empowering seniors, to really being their advocate, of creating their personal roadmap that they're in charge of, and including their families. We're a very consumer-driven product. We believe that the participant and member decides and is very formally involved in their care and all of their evolving needs in the future. Page 3. So what is PACE? The Program of All-Inclusive Care for the Elderly. You may or may not know, but it was actually developed in the 1960s, and it was part of the British Day model, and it came over to the United States in the 1970s and began in Unlock and with a very successful program for PACE. It really is interdisciplinary team directed. That is the secret sauce around what does PACE do and why has it been successful for this group of seniors. It integrates both Medicare and Medicaid funds, and it's completely focused on the entire person. We do a lot of work at InnovAge with the military and veterans, and we're beginning to see that it is now reaching out past just the dual eligible, but to some of the private pay as well. The wheel and spoke in the center of this document really kind of describes everything from the medical care to social determinants of health. So when you think of some of the infrastructure of PACE and what a lot of programs are trying to do, there's the answer right here of coordinating healthcare, bringing transportation in, having in-home assistance, managing the pharmacy piece, and all of the social engagements and dental and hearing. And we even do some light surgeries as well on the dental front. It's the preferred option to nursing facilities. We serve about 6,400 PACE members, and about 9% of the people we serve are actually in a nursing facility. The growth with PACE, although it continues to grow through the United States, has been small when you think of the 2.1 million PACE eligibles that are out there in the world. There is quite a group of people that need services. So currently it's serving about 52,000 folks across the country or nationwide. Page 4. So PACE services are really broken down into every component: primary care, physicians, nursing services, our behavioral health team, our social workers, restorative therapies. We even do acupuncture, personal care, nutrition, meals, transportation, lab, x-ray. Everything goes on in that center About the average of people come to the center about 3.5 days per week. At InnovAge, we've developed larger centers to be able to scale within communities. We recognized early on that the smaller type centers were difficult to develop from an operational standpoint. Flexible in-home support. What's great about this program of bringing everything together medically and the social determinants is being able to do it, having flexibility, being able to go to a participant's home, being able for them to come into the center when needing, having social activities. All of those things are just so important. We also do a lot of things from adding grab bars, wheelchair accessibility, putting ramps in the house, helping with laundry, walking the dog if needed. All of those things are really important. And when you think about your age at this point, you're 80 years old, about 69 to 70% of who we serve are females, often that they're alone. So having that support, being able to wrap that around them is very nurturing, but at the same point, really important when you think about their care plan and their utilization as well. Page 5. The impact on caregivers goes without saying is such a toll on the family, both psychologically and economically. And you can see that when a family member, and if any of you have ever taken care of your mom and dad, I certainly did, and I know how difficult and challenging this can be for your family members. We know economically it's about 25.2 annual loss in worker productivity, 13 billion additional employer health care costs for caregiving employees. So PACE helps reduce that burden and just keeps the family together. And I often say we're the bubble wrap around the families and around that participant that we serve. Page 6. So who's qualified for PACE? They live in a PACE service area. You know, it's currently done by zip codes that are awarded. It is a three-way party agreement between the state, the feds, and us as the provider. They have to be certified to a nursing home care, ability to live safely in the community with PACE support. 92% dually eligible for Medicaid and Medicare is the average. 75 years old, 69% are female, 31% are men, and 70% are living in the community. Top diagnosis, probably not surprising, diabetes, chronic complications, depression, COPD, chronic kidney disease, vascular. About 50% of our folks have dementia. Another over 50% have either a primary and secondary psychiatric diagnosis as well. And another thing we're seeing as time goes on is higher increase in substance abuse activities. Page 7. So alternatives to PACE, you've heard about some of them today. Obviously, you know, PACE does a lot of great things, and so do some other programs. And the dual institutional needs plans are out there that allow access for seniors to be part of those programs. The dual demo programs, we've seen and heard about those. MLTSS was also mentioned as way, and home and community-based type services. And, you know, when I really think about the volume of people with seniors that are out there, not one program fits everyone, and I think that's something for hopefully our regulators and people to understand, is that the people that we serve in PACE are certainly very frail. They are that 2.4 RAF score. They are the folks that need lots of assistance one way or another, and certainly couldn't do it without having that framework and that infrastructure around them. There are other folks that are healthy or dual eligible types of members and patients, and they do better in a less restrictive environment. So I think there's a combination out there that needs to be part of the discussion, that it's okay to have that combination. Page 8. We've heard this morning or this afternoon a lot about macro trends, and certainly PACE is that capitated model. I'm a firm believer in capitation and the capitated model. We know that we've had a lot of lack of coordination out there. There's been failures of other programs. some of them due to economic failures and some of them just due to not embracing consumer choice at the end of the day. We know that PACE has had support of both political parties on both the Democratic side and the Republican side. And we know that we've saved some of the states and the federal government somewhere between 15 and 30%. Page 9. So as I mentioned, there are about 2.1 million dual eligibles in the U.S. that are estimated to be PACE eligible. We believe it is a great policy alternative to serve low-income frail seniors and to deliver integrated acute care or long-term care and be able to do it well. And I think that's so important to people that are providers of care, is to really do it well. And the risk model as well. And just putting all of those pieces together to serve that Medicare and Medicaid beneficiary. We know that PACE extends life for about a year or more, and there's been a lot of discussion around that on extending life and what that means. But we also know that it reduces institutionalization and it improves quality of care, and as I mentioned earlier, hold families together. We've had a long history of successfully providing community-based, high-quality, integrated care, and I think it's something that other providers and people in need can learn from as well, because there are very important pieces of the PACE model that make it successful in really taking care of that frail seniors. There's been numerous studies on PACE that have demonstrated positive health outcomes, and there needs to be more data and research on the cost-saving nature of PACE as well. Next page, please. So a little bit about InnovAge. We've been around since 1989. We're actually about 6,400 members served today. We operate in 5 states, soon to be 6. We have 16 current PACE centers, and we are the largest currently in the country. We grow organically about 14%. Next page. And here are the states we're located in Colorado, 6 centers. California, we have 1 in San Bernardino. We have 1 under construction now in Sacramento, and we're in a joint venture with the Adventist Health System. New Mexico, Pennsylvania, and Virginia. Next slide. Next slide, please. And then here's just some pictures of what our organization looks like and how our centers are developed from the bricks and mortar standpoint. And we average about anywhere from 24,000 square feet to our largest in Sacramento, which is 68,000 square feet. So thank you very much for including me. And to learn more, you can come to www.myinnovage.com. Thank you.
Great. Thank you, Maureen. Now we are going to turn to the question and answer portion of this meeting. Just as a reminder, you can still submit questions for all of our presenters today by typing them into the questions pane, which is located at the bottom of your control panel. So I'm just going to get us going by starting ask one question to the group. Could you all address how you see the issue of long-term care progressing as the aging population continues to grow, and talk about the burdens that will continue to fall on caregivers or how they might change as a result?
Well, this is Ann. I'll start off. It's a great question, very broad question. And I do think that long-term care, from my perspective, maybe it's because I've been looking at it for so long and am so interested in it, but it will become more and more important, as a part of our healthcare system, really, because of the demographics that we were talking about and the shift toward a much older population. And also, of course, many younger people with disabilities are also living to old age as well, which is wonderful. So I think it just keeps growing, and we need to keep therefore, creating expanded and more cost-effective versions of what we already have, and also try some new programs of the sort that we were discussing earlier. We didn't talk about some of the other ideas, and happy to do that. For example, I know that I think Catherine was going to talk about a strategy to support catastrophic coverage, which is, the tail end of long-term care. And I think we should definitely look at that as well. There's a proposal out there from Mark Cohen and Judy Fader and Melissa Favreau, if I'm saying her name right, that would basically put that in place, and the additional payroll taxes that people would pay would be pretty lean compared to what we've seen in the past, and it seems like a great thing to look at. I don't know that that would be able to be implemented in time to help the boomer population, which is aging into Medicare as we speak. So there's a variety of things, really, short-term and intermediate term and longer term, that I think we need to do. And I think Jean and others expressed very, very well that the sort of default mechanism of having families, and specifically those who are providing the care, family caregivers, of their own free will and out of their own generosity, simply cannot be the default at this point for many, many reasons. And so we will need to support people more, but we more than that, family caregivers more, we need to develop a more robust system of formal services. And there's one other thing I'll say real quick, and that is that we could do more with volunteerism. And there's an interesting program out there that some of you may be interested in following. It's not there yet, but it will be soon. It's called the Community Care Corps. And this is something that the Administration for Community Living is putting forward. And they put out an agreement, a cooperative bidding agreement, and we are part of the team that won that. And effectively, it will stand up volunteer programs or expand existing volunteer programs all over the country of people who really want to give back to their community, so be very grassroots oriented, and with appropriate training can go in and help people who are isolated, who are trying to age in place. They will not provide any medical care, any personal care. They will only do instrumental activities of daily living. But that is enormously important, and something that I think we probably will not be able to field a large enough paid workforce to take care of people in that regard. So there are all kinds of answers. Those are just a few.
Just to add on to what Ann just laid out, I think there's a couple of things, particularly at the federal level. We do have the Raise Family Caregivers Act that was signed into law early last year, January 22nd of 2018, and directs the Secretary of HHS to develop, maintain, and update a national family caregiving strategy. That would include a couple of things. One is some of the things we talked about today around greater adoption of person and family-centered care, ensuring that there's assessment and service planning involved, that there's respite options for family caregivers, and now we do have the Raise Family Caregiving Advisory Council, which is advising the Secretary of HHS on these issues, and its sunset is currently scheduled to sunset on January 22nd, 2021. But with the Dignity Aging Act, which was passed to the House of Representatives, which would reauthorize and extend the Older Americans Act, it also included some language around extending the RAISE Act, which would be extremely beneficial. On the state level, one of the things that has been exciting to see is a lot of passage around the Caregiver Advise, Record, and Enable Act, which does three things. One is it indicates that if it's important to identify the family caregiver in the medical record, it's important to ensure that the family caregiver has adequate notification of a discharge, and that the third, there should be training for the family caregiver if the care is going to be dependent on that particular individual to provide the care. And this is in relation to performing medical nursing tasks. Again, as I indicated earlier, around injections and wound care and tube feedings and the like. And the great news is the fact that the Caregiver Advise and Record and Enable Act, what we refer to as the CARE Act, which was a model piece of legislation that ARP championed, has been enacted in 43 states. And we're currently in the process of doing an environmental scan just to get a better understanding in terms of what is actually how the states are implementing the act and what are some of the promising practices. And we hope to be able to provide some insights once we're done with our environmental scan. And then the other thing I would just quickly say is that we're seeing growing momentum and support for paid family leave in the workplace. 60% of all caregivers are working, and 8 states and DC have or will soon have such policies. So I think that while there's clearly challenges ahead. We're seeing a lot of opportunities. And then finally, from a delivery system perspective, I think that we're also seeing different types of models, and we heard several on the call today. One I would just throw out there that I think is very innovative is the villages model, which is basically neighbors helping neighbors, and it's grassroots, and there's over 300 villages in the US, and there's been some studies that have shown that those models are having a positive impact, particularly on quality of life and also health outcomes.
Great. Well, actually, Dean, that brings me to actually a question from one of our participants related to FMLA, which is, the question is, curious if anyone in the group has looked at the issue of FMLA or the Family Medical Leave Act of not protecting the job security of family members not in a parent-child relationship, i.e. an aunt and niece, who need to provide care to childless family members but would not have any job protection via FMLA if they needed to have a period of time where they weren't at work to assist a relative.
This is Maureen with InnovAge. We have embraced that as part of our company culture of being able to help our family members. As a matter of fact, many of the participants that are enrolled in our program, their sons and daughters work and are employed by InnovAge. But when people need to go, you can't really walk the talk without doing some of that. And being able to help people take care of their families. Life is complicated at the end of the day. It's just a complicated thing, and it's busy, and if you're sandwiched between kids and parents, it's becomes very complicated. You know, is there formal things and that are written up on it in our organization? No, they're not formal, but I will tell you we do practice it.
Mm-hmm.
This is Jane. One of the things I would just mention in our scorecard, we actually incorporated as one of the indicators around support for working family caregivers. And what we found, we wanted to include some measure that ensured that looked at FMLA in ensuring that what states were going above the minimum requirements, particularly with regards to FMLA. And what we found was the fact that nearly 1/4 of the states, again, this was around maybe 12 states, exceeded the FMLA's floor of protections, with DC leading the nation with the most progressive coverage. We'll be releasing the updated scorecard next year, and it'll be interesting to see exactly where we are. But at least according from the time that we did this report in 2017, there were at least 12 states that exceeded the FMLA floor of protections, with DC leading the nation. And then just to add on to what Maureen said, at AARP, we have, in addition to sick leave and time off, that we have a caregiving leave benefit that allows staff to take up to 2 weeks to care for a family member or a loved one. And they can take it at any point in time, and they can take it consecutively. And then we also have a pool for a drastic situation where there may be a staff member who need more assistance.
Mm-hmm. And this is Ann. I would just add that there is some interesting legislation out there that folks might want to be aware of. It's the Family Act. It's been introduced in the House and the Senate, I think, for several Congresses. And it would essentially create paid leave for a range of people to help their parents, their spouses, their domestic partners, their children, also some other kinds of situations that it would cover, and effectively would build on some of the work that's been done in several states, including California, to pioneer paid leave. You'd have employees and employers paying into a fund, and then you'd have an office administering the distributions. So it's a really good step forward, I think, if we can get there. I don't know what the prospects for it are, but it is definitely out there. And to some extent, there is a move to sort of build on that idea in a proposal that the National Academy of Social Insurance has put forward, which is and Caring Across Generations, and it's called Universal Family Care. And those are essentially ideas to provide payments and other forms of support to really across the lifetime to people who need that help, to help family caregivers. So that's a particularly ambitious and very fascinating proposal, and I know they're out there in the States talking to lots of people about it.
Great, thanks so much. I want to move on to one other question, which is about state level policies. Can you all discuss, so what are some of the successful state level policies that we've seen from some of the above average states that potentially could be translated into other states that have a lower rates of HCBS spending? So what can be learned from those places?
Hi, this is Camille. Well, some of it is sort of the approach that the state takes. A number of the states that are sort of leader states had a strong state-funded infrastructure for HCBS before they expanded and started serving Medicaid patients, Medicaid consumers. You know, you can only serve more people in the community if you actually have providers and capacity for it. Those states have been very creative in using shared living arrangements, allowing self-direction for consumers to hire their own care worker, potentially family members. And so it's a combination of a number of policies that have led to the typical infrastructure that works for those states. You know, honestly, I think in a number of states, the reason that those states are sort of lower on the list is the financing arrangements that states have in place for their Medicaid program through nursing home taxes and payments, and that's a challenge to sort of overcome for states that are challenged to finance their program through general tax revenue. So that's another barrier. It's very, very complicated, and I think each state's structure is very unique. There are not a lot of policies that I think can translate from state to state, but they do spend a lot of time talking to each other, certainly about coverage policies and those things that would make HCBS more readily available.
Mm-hmm. And this is Anne. I'll just say that Camille and I had the pleasure of being part of a roundtable a little over a year ago that the National Governors Association put on, and out of that came, I think, a very good paper, and you all might be interested in reading it. I'm sure it's available on their website. It's called Improving the Health and Well-Being of the Nation's Aging Population, Considerations for Governors. And so it really came out of a bunch of discussion between states and what they were doing to try to kind of improve on what they have, which, as Camille said, is really quite different from state to state. But there are some very innovative things going on. For example, Washington State has an 1115 waiver that actually allows caregivers, family caregivers, to receive a narrow band of services to support them, because they're supporting somebody who isn't eligible yet for Medicaid, but who otherwise would be needing, full-time care, perhaps in a nursing home. So it's a win-win, for both the family who really doesn't want to have their loved one necessarily placed too early in a long-term care setting, and also for the state, which spends a lot less. So there are all kinds of very important things, I think, going on at the state level, and I know Advancing States is keeping up with all those developments as well.
So I wonder if we could just piggyback on that really quickly, and maybe Camille, you could talk about this for a second, which is Washington State this year became the first state in the country to create a state-run long-term care insurance benefit. And there's a question about whether are there similar programs being considered by other states, or any bills or amendments to federal programs that are being considered in Congress.
Not that I'm aware of. I think, as you could see from the AARP scorecard and sort of Washington's ranking on HCBS expenditures, they are very progressive. state in terms of taking on the challenges of the demands for HCBS in a number of areas. As Ann mentioned, their TSOA program, this is only, I think, the latest attempt for them to really take the challenge really head on. My understanding is that there aren't other states that have anything that look like this currently percolating, nor do I think there's anything imminent on the federal level. But maybe either Jean or Ann might know that.
I guess I would say, this is Ann, that, yeah, I think Washington is out ahead, and maybe it has been for a while, but there are other states. We're actually headquartered in Michigan, and Michigan is one of those states that's now doing a lot of thinking. You know, there's a study that they're now engaged in, and we're part of that. Some of my Michigan colleagues are gearing up to work on that, and they're going to look at public-private partnerships and workforce. I think we're doing the workforce piece. And so they will come out with a plan, you know, in 2 years, I think, and try and figure out what to do with that plan once they've got it. So I think there's a fair amount of that going on. And I guess we should mention Hawaii for sure, which maybe took the lead, you could say, in pioneering a cash payment. I think it's $70 a day for families who are supporting, caregivers who are supporting a loved one and need to, you know, cut back on work perhaps. In order to do that. So I think we'll see more and more. It's probably early days, but I think states are going to try to be creative. And there doesn't seem to be a big federal bill that's moving forward in that regard. Not yet. I mean, there are, of course, some interesting proposals. I don't believe he's introduced it, but Representative Frank Pallone, now chairman of Energy and Commerce, had a bill out for discussion a year or so ago. And so I know he's thinking about this subject. Ways and Means just had a hearing last week, and the members were really very interested and very engaged, and particularly around family caregivers. And all of them have their own story about long-term care and why it's important to pay attention to it. It was remarkably bipartisan. That was very interesting. Some of the Medicare for All proposals have a long-term care piece in them. So I think I take that as a sign of people are thinking about this, even if they're not ready to act right away.
Great. One other question that we have here is for the group, given the high number of family caregivers and the value that they provide, would a tax incentive to these caregivers encourage more families to continue to provide that care to their relatives?
Do you want to take that one, Jean? I'm thinking.
I was on mute. I know that there's some states who are actually looking at tax credits for family caregivers, as we talked about earlier, just given the significant out-of-pocket costs that they are contributing in terms of just their own out-of-pocket costs, in addition to the value that they're providing overall. I do think that there's some merit to thinking about ways in which to provide some additional support, whether that is in the form of a tax credit or in some cases respite care and some other benefits.
Mm-hmm. Yeah, I'll just say, and I think this is kind of noteworthy, that we did a little bit of polling. I know AARP does a lot of polling leading up, in this case, to the 2016 election, and it was exit polling. So people had already voted when they talked to the pollsters, and we bought a couple of questions in this poll, a national poll. And the questions we wanted to ask were about direct care workers and family caregivers. And so we had one question that said, which of the following do you think would be most helpful for families who are supporting someone who's ill, elderly, or disabled? And there were 3 choices. Financial help for family caregivers, so that could be a tax credit, for example, or a payment. Easier access to care workers and in-home services. Making housing suitable for people with disabilities. There was not an option for all of the above, but that's what people chose in great numbers. And it was on, you know, both sides of the aisle, both Republicans and Democrats. So they volunteered that response. It wasn't one that was given to them, and that's unusual. The pollsters tell us people don't usually do that. So I think what it tells us, and I don't believe that's probably changed, is that people know there's a big problem out there, and there are huge gaps, and they want solutions, and they want solutions in many forms. They would welcome them.
Absolutely. And AARP has been very involved, particularly with the Credit for Caring Act, which would provide some financial support to family caregivers for many of the reasons why we talked about today. So it is an area of focus. We know that there's some bipartisan interest, particularly around supporting family caregivers with some form of a tax credit, and we look forward to helping to move that along.
Great. Well, unfortunately, we are running up against the amount of time that we have today. So I'm going to turn things back over to Catherine to make some closing comments.
Great. Thank you all. Yes, and thank you all for your engagement today and for submitting your great questions. I know we barely scratched the surface with this topic, so the Alliance hopes to cover this long-term care further in 2020. We'll have to have our wonderful panelists and moderator back. If you have time this afternoon, you'll get an email later today with a brief evaluation, and we really value your input. Definitely put comments about other topics, both in long-term care or otherwise, that we should be covering. For those of you that are in DC, we also have an in-person briefing on a completely different topic on cell and gene therapies. So look out for that on December 4th. We're also going to have a final webinar in our webinar series this year, likely on the Texas v. Azar decision, if that comes out in the next couple of weeks, as everyone is suspecting. So look out for that as well. And then finally, as we do some planning for 2020, would love your thoughts. So please go to allhealthpolicy.org and fill out our longer audience survey to give us some feedback on our programming. And with that, I will thank everyone again for joining. Thank you to our panelists and moderator, and that will end the broadcast.